it dyspnea. Actually, dyspnea is when the patient experiences shortness of breath at rest, but we can use them interchangeably. So what's this shortness of breath, or how can we define dyspnea? The American Thoracic Society define dyspnea. It is subjective experience of difficulty of breathing as it is reported by the patient. This is a definition that is given by American Thoracic Society. So when you see this dyspnea, usually it's difficult to quantify. Like pain, it's also difficult, but different institutions use different scoring or quantifications of this shortness of breath. For example, COPD patient, we use the gold staging, and additionally we also use MMR, modified medical research dyspnea scale. For heart failure patients, we use the NIHA classes. It is a New York Heart Association tries to put different classes of heart failure based on the dyspnea they experience. So we may quantify them based on using these scales, but it's usually difficult to quantify dyspnea, rather it's subjective experience. But we may see the severity or the degree of that shortness of breath by additional features on our physical findings, like presence of tachypnea, the presence of subcostal, intercostal retraction, or the use of those accessory respiratory muscles. We may know that the patient we may know the degree or the severity of dyspnea. So if you say this much about dyspnea, what the mechanism? So we have to know the mechanism of dyspnea. It is a gameplay between the respiratory system and the central nervous system. So the respiratory system will send a message to the central nervous system, and the central nervous system will give the response based on the question asked by the respiratory system. So how do the respiratory system send the message to the central nervous system? We have different receptors. Different receptors are responsible for this. So those receptors will pass information, will activate those afferent fibers and send the message to central nervous system. So what are these receptors? These receptors are, one is mechanical receptors, which are found in our respiratory tracts. There are stretch receptors, irritant receptors, J receptors. These receptors are found in the lining of the respiratory tracts, and there are also stretch receptors on our chest wall muscles. So when they are stretched, they will be activated. So the afferent fibers will take the message to the respiratory center. So the one of the source of the information is these mechanoreceptors. The second one is chemoreceptors. So these chemoreceptors we call them peripheral chemoreceptors, and they are found in the aortic arch, and in the carotid body. They are sensitive for low oxygenation of blood. So when there is hypoxia, hypercapnia, and when there is acidosis, they will be stimulated. So that afferent pathway will be activated and send the message to the respiratory center. The third types of receptor is found within the pulmonary vasculatures. In our pulmonary vessels, there are baroreceptors, which are sensitive to pressure. So when there is increasing pressures within these pulmonary vasculatures, they will be stimulated and they will send the message to the respiratory center. From the respiratory center, which is found in the brain stem, will send the message to the higher center or to the cortex. So the body will give its response through the afferent fibers. So using the vagus nerve, the phrenic nerve, and the like, it will activate all the work of the respiratory muscles in order to increase the oxygenation of the blood. So that's the point when the patient will experience dyspnea or feeling of air hunger or chest tightness. So this is the mechanism how the patient develops shortness of breath. If we understand this, now how do we characterize patient presented with shortness of breath? This is our major objective of discussion. You can leave the remaining things. The details of the disease will be discussed on our future bedsides, don't worry. How do we characterize this shortness of breath? So what questions should be asked to the patient? So it will help us to reach on the diagnosis. The most important thing is always you should know that 85% of the cause of dyspnea is associated with cardiopulmonary pathologies, and the other 50% is associated with systemic problems. If we see closely, it is usually associated with the diseases which arise from the lung and the heart. From the lung, patient may develop dyspnea from diseases which arise from the airways and respiratory airways, like patients with asthma, COPD, bronchitis, chronic bronchitis, and the likes are associated with airway disease, or they may arise from the underlying from the lung parenchyma, like patients with tuberculosis, lung abscess, patients with lung C, interstitial lung disease. These arise from parenchymal lung diseases. Or the shortness of breath might be from the problem within the pulmonary vasculatures. So commonly pulmonary hypertension. There are a number of etiologies for pulmonary hypertension, but among the most common one is pulmonary embolism. The other thing is shortness of breath can be the problem within the pleura. So from the pleura there might be malignancies, there might be infections, or there might be surgical conditions like tension pneumothorax. All these things conditions may result in shortness of breath. The other thing is the problem can be from the chest wall, like chest wall deformities like kyphoscoliosis, or it may arise from the weakness of the muscles, which are formed on our chest wall, like myasthenia gravis. So all these conditions may result, pulmonary or underlying lung conditions may result in that dyspnea. From the cardiac causes, it may arise from heart failure. Patients with pericarditis can develop this shortness of breath. Other thing is the dyspnea or the shortness of breath can be from anemia, obesity, sarcoidosis, and the like. So all these disease entities results in shortness of breath. The main work of the physician or the one who is clerking this patient, major objective is identify from all this which one is the cause of the shortness of breath specifically in this patient. In order to know this, we have to characterize the shortness of breath. How do we characterize the shortness of breath? One thing is knowing the duration. As I've always mentioned, every symptom should have a duration because it's very relevant, very important. Based on the duration, shortness of breath can be acute or chronic. So acute dyspnea, usually it results from acute insults like myocardial infarction, like pneumonia or exacerbation of asthma or pulmonary embolism. And chronic cause of dyspnea usually results from long-standing pathologic process like lung CA or interstitial lung diseases or obstructive lung disease and the like. So we need to differentiate whether it is acute or chronic. Usually by definition, chronic is when it lasts more than 3 months. So if we know the duration, the next thing is we need to know at which position of the patient that the dyspnea is worsening. For example, if the patient has orthopnea means the patient experiences the shortness of breath when he is on sleeping position or when he lies on his back without a pillow, the patient will experience the dyspnea or shortness of breath. Orthopnea can be due to the heart failure, or it can be from the obesity, or it can be from the ascites, or it can be from anything which increases intra-abdominal pressure. Knowing that the patient has orthopnea or the shortness of breath is worsened when he is not using a pillow, then we can know our differentials to these disease entities. The other thing is the patient may experience the shortness of breath when he is on standing position. So in this area, I'll consider for the presence of tumor within the left atrium. Usually we call it myxoma. Actually, it's not a common disease condition. The other thing, it can also be from hepatopulmonary syndrome. The platypnea can arise from these disease conditions. And other position-dependent shortness of breath is PND. It's an abbreviation which is paroxysmal nocturnal dyspnea. So this condition is typically associated with heart failure. So PND is when the patient experiences the shortness of breath after taking for a sleep for a few hours. He will wake up after 3 to 4 hours of sleep, and he will wake up from sleeping, and he will experience a shortness of breath and feeling of being dead, or as if he is survived from death. So immediately we go to the window in order to get more air. In this scenario, this is the typical features of breathing, and it's a typical feature of heart failure. Knowing the position, at which position the shortness of breath is worsened, is very important. So the other thing that we should know is if there is any diurnal variation of shortness of breath, especially if it worsens during the night time or early in the morning, you should consider asthma as a cause of the dyspnea. So I will ask him at which time of the day that the shortness of breath is worsened. He may say there is no diurnal variation, or he may tell you that specifically the dyspnea is worsened during the night time. So the other thing I should know is exacerbating and relieving factors. Usually for dyspnea, it's exacerbated by exercise, and usually it's relieved by rest. This is common thing for most of the dyspnea, so always we have to assess. The other important thing is we have to assess for associated symptoms. As I have mentioned earlier, there are a lot of differential diagnoses for shortness of breath. So in order to rule out those differential diagnoses, I should ask the symptom of each of those differential diagnoses, so that it will help me to rule out almost majority of the diseases. So it will narrow my differential diagnosis. I can easily decide the line of my investigations and diagnosis.
Now let's take one sample history showing the characterization of shortness of breath. Our patient Mr. Muhammad presented with a chief complaint of exacerbation of shortness of breath of 1 week duration, and we can see the characterization of shortness of breath on the history of present illness as follows. He is presented with shortness of breath of 1 month duration, which was initially experienced when he moves out of his home, and 2 weeks later he experienced it with less ordinary activities like going to toilet. 1 week prior to admission, he experienced the shortness of breath while he is at rest. So from these sentences we can understand that one is the duration of the shortness of breath is mentioned, so we can differentiate it whether it's acute or chronic dyspnea. The other thing is it shows the progression of the shortness of breath, which starts from being unable to do ordinary activities to the level of rest. So this shows us the progression of the shortness of breath, which is important to be mentioned on the characterization of dyspnea. And it will continue as follows. Associated with this, he has shortness of breath and cough when he is on supine position, for which he uses 2 up to 3 pillows to relieve symptoms of 1 week duration. So this sentence explains the position in which the patient experienced that shortness of breath, which means the orthopnea. In addition to this, he experienced shortness of breath that wakes him after a few hours of sleep, for which his sleeping pattern is disturbed for the same duration. So this patient has PND, and as I have told you earlier, PND is a typical feature of heart failure. Finally, we mentioned the associated symptoms like dry cough, palpitation, weight loss, and loss of appetite. So this will help us to narrow our differential diagnosis.
So this is important things that we should keep in mind while characterizing a patient presented with shortness of breath.